All right. Hello, everyone, and welcome. If you're here for the glaucoma lecture with Dr. Simber, you're in the right place. And it takes a minute or two for everyone to get logged in here. So while we're doing that, I have a polling question that I'm going to. It got lost. No polling question. Sorry. Um, I won't do a polling question. I was going to ask about the NFL. If everyone thinks that there was going to be a season this year. And the answers were yes, no, and who cares? I wanted to see what the response was, but I lost my polling question. So waiting for everyone to log in here, and we'll go from there. Thank you. Just give it about another 30 seconds. All right. So while people are logging in, I'll do some housekeeping. I'm Dr. Greg Caldwell. I'm going to do some housekeeping. We got Dr. Simber here, who's our speaker, and Dr. Saka, partner and optometric education consultants. And he'll have the pleasure here of introducing our speaker, Dr. Simber. With that being said, there is a handout. I believe the handout we just uploaded. Hopefully it's still there for you, Mike, if you want to launch that. We will put you can put questions in the chat box. I will monitor the chat box, and Dr. Simber will answer those questions that are out there. This course is being recorded, and then we'll most likely upload it to our YouTube channel for anyone that wants to replay it. You will get a replay link within 24 hours. However, the replay link doesn't last forever, so that's why we've created the YouTube channel so that people can go back and watch it. Optometric Education Consultants, it's on YouTube. A survey will be sent in about 2 hours. I'm going to try and get the correct survey. I was just notified that the other survey is not the wrong survey is connected to it, so I'll try and get it to you. If not, we'll get the correct survey out to you within a day or two. The best way to do things here is don't compete with the bandwidth. So don't try and watch a movie or try and do emails. Webinar Jams is a cloud-based service. Everything's sitting in the cloud and it's being streamed to you right now. So if you have competing Wi-Fis, and we have Ring doorbells and refrigerators and all these things that are connected to our Wi-Fi at home, and that puts a stress on it, and that's usually what slows things down. So if you have children that are playing on Xbox or spouses that are doing the same thing or watching movies on iPads, that will stress the system. So the best thing that you could do is decrease your bandwidth. Again, chats will be a great place for questions, and I'll help monitor those. And Vanessa, our conference coordinator, will send your information to Arbo for the COPE credit. She'll also email you a certificate of attendance, probably, since this is Wednesday, probably early next week or later in the week. So usually it takes her a few days to kind of verify everything, and you'll get your certificate via email with the email that you used to register for this webinar. And we'll get them off the COPE as long as you supplied your OE tracker number. So I think I got everything there, Joe. We can get started here. Looks like everyone's logged in. We can introduce Dr. Simber.
Yes, I'd like to introduce Dr. Michael Simber, who received his optometric doctorate from the Pennsylvania College of Optometry at Salus University. He also completed a residency at the Wilkes-Barre VA Medical Center. He was awarded the Young Optometrist of the Year by the American Optometric Association in 2001. He's a fellow in the American Academy of Optometry. He is a medical director of the Glaucoma Institute of State College and member of the Optometric Glaucoma Society and the National Glaucoma Society. He is an ocular disease lecturer, researcher, and has published in numerous journals and publications. He is also an adjunct clinical professor at Pennsylvania College of Optometry at Salus University. Finally, I think the last thing to say is he is a managing partner at the Eye Associates. So it's really my great pleasure to introduce Dr. Simber and thank him for participating this evening. With that, take it away.
Thank you very much, Dr. Salka, and thank you, Dr. Caldwell, for this opportunity, and everyone at Optometric Consultants. Happy to be a part of this. They do a lot of great work for our profession, and I'm pleased to be a part of it this evening. Are you seeing my screen now?
Not just yet.
Okay.
Up in the top part, there should be 4 little circles. Do you see those circles?
I don't. Let's do this. Okay, so I'm back on. Yeah. Okay, got it.
Turn screen share on.
Yeah.
Third one over.
Okay, good. All right. So are you seeing my screen now?
Not just yet. Greg?
PowerPoint's open in the background there, Mike.
Yes.
There you go.
Now you're getting it.
Perfect. Just go to PowerPoint mode and you're good.
Okay, good. Thank you. All right. So welcome, everyone. It's good to be here to share this with you tonight. So we're really coming out of the COVID fog. So we're going to talk about 10 ways to jumpstart your glaucoma practice. So here are my disclosures. But of course, this course was prepared and presented without commercial bias. So I'm in a tale of two professional situations at Nittany Eye Associates. On our left is our group of optometrists, and this is really for 20 some odd years. I practiced full scope optometry like many of you. But about 3 or 4 years ago, we had a glaucoma specialist, Dr. Parekh, join our practice. And so we had a discussion shortly after he joined as a consultant within our practice, and we said, what can we do to elevate the level of glaucoma care within State College? So we decided together to create this Glaucoma Institute. So for the last 3 to 4 years, I've had an opportunity to be a referral glaucoma center, but I still do practice primary care optometry, so I feel like I have a good understanding from kind of both sides of the fence. So here are several ways to reach out to me. We do have a handout that will be provided to you through the portal that we have going tonight. But you can also go to my website for handouts. You can see those there if you want to contact me by email or by LinkedIn. All of those ways you can communicate with me ongoing if you would like. So COVID came and affected our practices in a big way, and it was almost instantaneous, wasn't it? Where we were just cruising along, and then one day we realized we have to shut down. And this is what it kind of felt like within our practices. And then came the barrenness. We saw our revenues plummet like everyone else, and it was a very difficult time, a very scary time. Speaking of which, this is a picture of myself and my daughter when we were attending the Clemson Alabama championship 2 years ago. Well, my daughter is going into her senior year at Clemson, and so in South Carolina, they're not doing a great job in terms of social distancing or masking. Everything is kind of opening up. So to make a long story short, I have a personal experience with COVID in that my daughter got it. And there were some scary times that we had before she actually turned the corner, and now she's been, that was about 2 weeks ago, she's doing fantastic now. But it can be a scary thing, when a family member gets it, when my daughter gets it, when someone in the office gets it, and what are we going to do about that? So many different levels there. I noticed, and I'm sure many of you noticed, that when we had to shut down, there were many online vendors that really went wild with advertising, advertising glasses, contact lenses, all of those things. So it was a very difficult time for us, but we have to remember that threats and challenges have always been a part of our survival, optometry survival, and always will be. COVID certainly has accelerated those threats, and we have to respond in the right way. And now more than ever, we need to embrace change. The glass is not half empty. There are many opportunities for growth. So one of those areas of growth could be in a more thorough embrace of the medical model. And I'll kind of share this quote that comes from Martin Luther King Jr. The ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy. And that's really kind of the time that we're experiencing, both from COVID and some of the social issues within our country today. When we think of optometry, it's hard not to think of this from our roots of optometry. This is kind of where our profession started. And when I graduated in '96 in a residency in '97 and came out and started, practicing optometry, this is really where the majority of our revenue was coming from: glasses, contact lenses, eye exams, those kind of things. Everything else was kind of secondary to that. But as time has gone by and we have evolved as a profession, really further optometric adaptation to the medical model is necessary to remain relevant. And so, at least in my practice, and for many of you, we have testing, we have pharmaceuticals, we have the clinical part of our exam, we have nutraceuticals. All of those are now shifting, kind of shifting the balance of where our revenue comes from. And so I think if there's anything that the COVID taught us, and it has taught me many, many different things, it's teaching me that we as a profession have to continue moving towards the medical model and embrace it. And that's really what tonight is all about. What are ways that, if your glaucoma practice is thriving, hey, great, you'll pick up a couple pearls about tonight that hopefully will be useful. But if it's not thriving, what changes can you make to your glaucoma practice to be better, because really our patients deserve it. They deserve it, and no one can provide it better than us. So we're going to talk about 10 ways to jumpstart your glaucoma practice. And the first way, in many ways, involves knowing what you're dealing with, maybe even before you walk into the exam room. So we have, within our Glaucoma Institute, we have a list of risk factors. And before I even walk into the exam room to examine the patient clinically, I have a list of these risk factors. These risk factors are provided within the portal. And at some point, Greg, you might have to tell me how to share those with the audience. But we have a list of these risk factors. So before I even walk in, I have a pretty good understanding of what our patient's risk factors are. And I'm not just talking about, does your patient have glaucoma, meaning conversion, but what if it's an established glaucoma patient? What's their risk of progressing? So we think about the risk of conversion and the risk of progressing, somewhat independently. So here are the risk factors risk factors for conversion, and I break those down as coming from the history or coming from the clinical exam. So from a history, we can tell, okay, what is the family history? Do they have a sibling that had it? Did they have a parent? Did they have a grandparent? Which is the most important? Well, we probably know, everyone on this call knows that the sibling is the most important risk factor, particularly as it relates to exfoliation or pseudo-exfoliation that we'll talk about a little bit more. Smoking is a risk factor. Low blood pressure is a risk factor. Sleep apnea is a risk factor. And if they have it, were they prescribed a CPAP machine? Are they using it on a regular basis? Are they using hypertensive medications, and are they using hypertensive medications at night? I had a recent example of a patient with glaucoma who was using a calcium channel blocker and was using it in the morning, but his blood pressure, his primary care felt the blood pressure was a little too high, so added a second dose. But he was taking it right before bed, and about 2 or 3 days after he started taking it at bedtime, he called me and said, "I'm really having a hard time here. I feel like my visual field defect is getting larger." So we had him come into the office. We ran some tests, and sure enough, we concluded that nighttime dose was lowering his his perfusion pressure to a dangerous level. So we called up the primary care doctor and made some adjustments in that. So that's one thing to look out for. Obesity is a risk factor. Diabetes greater than 10 years. If there's circulation issues like migraines or Raynaud's or especially high cholesterol, that's one of our newest risk factors for conversion to glaucoma risk. And then there are the clinical aspects. Exfoliation being one, a huge risk factor is exfoliation. And so much so that if the patient has exfoliation or pseudo-exfoliation, if you really want to tell them to have their brother, sister get tested for sure. If the patient has it but doesn't have raised eye pressure, or you're convinced doesn't have glaucoma, follow them at a minimum of 6 months. Disc hemorrhages, that's a huge risk factor for conversion. Can't tell you how many times that's a way that we can make the diagnosis, that gets on our radar initially, and we eventually conclude that they're losing nerve fiber layer exactly where they have that disc hemorrhage. So when you see it, make sure you note exactly where it is, and every time they come in, remember that. Make a mental note of that. Thinner central corneal thickness, as we know, is a risk factor for conversion, and also a lower hysteresis is a risk factor for conversion. And again, we're going to share all of these risk factors for you. You'll have a handout that you'll be able to utilize within your office if you would like to. Let's next talk about risk profiles for progression, because they're slightly different. So from history, we can get high cholesterol. High cholesterol is a risk factor. Age is a risk factor for glaucomatous progression. And then there are a host of clinical risk factors, which include having a higher Tmax. What was their highest pressure overall? A really important factor. If you're sending your patient on for secondary glaucoma care, always try to include the Tmax in your referral. It makes it much easier, I think, for the referral acceptor to make good decisions. What's the highest, or what's the higher mean intraocular pressure? So Tmax is one aspect, mean IOP is another. What's the thinnest, or what's their central corneal thickness? Having a thinner central corneal thickness is a risk factor. Exfoliation or pseudo-exfoliation. You'll hear pseudo-exfoliation more commonly now referred to exfoliation in the research. So don't miss that curveball that may come at you. Disc hemorrhages are not only a risk factor for conversion, but also progression. So pay close attention to those. A low ocular perfusion pressure, as I mentioned in the previous example, and then a lower corneal hysteresis. These are all risk factors for progression, and important to note those. All right, so that is one important factor. The second important, the second way to jumpstart your glaucoma practice is, and this is an homage to a song that came out in the '90s that says, are you down with OCT? Yes, you know me, but are you familiar with OCT to the level that you should be? I'm still learning the things about my OCT probably every week. So we need to not just get it and get the instrument and be comfortable with it. We have to continually mine the information that's out there so that we know exactly what we're getting from our OCT. And so we're going to just briefly kind of touch upon this, and this is actually a separate, a completely, I've done just an OCT interpretation webinar for 1 hour or 2 hours. We're going to do it now probably in about 10 or 15 minutes. So the information is going to come at you in a flurry, but try to grab on to what you possibly can. And even though my examples will be OptoView from the OptoView Avante, because that's what we use in our practice, it's going to be applicable to whatever instrument that you're using out there. So really kind of 5 areas of interest: the circumpapillary scan, the optic nerve head map and nerve fiber layer, the ganglion cell complex, the TISNIT or the NSTIN, and then progression. That's what we're going to hit upon next. The circumpapillary scan is kind of one nice thing to look at, that for many years I paid no attention to the circumpapillary scan. With that said, it's extremely important because that is really kind of the data that you're mining everything else from. And so we're taking a scan that's around the optic nerve here, and we can kind of see all of the different layers. So if there's an area that you think is being thinned, it's always good to go back to the circumpapillary scan to make sure that it's registering those different layers correctly, because sometimes there are errors, particularly if it's not an accurate scan. So it's always good to go back and look at the circumpapillary scan. The OCT reference database is also an important concept because many of these databases, and these are just kind of some cursory database information, we can see that many of them only go to a certain amount of myopia. So there's a -7 in there. There is a -12, which is good. There's a -8. So if I use the Avante, as I mentioned, if I have a -9 patient or a -10 patient, it may be confusing the normative database, and it may give me readings that can be confusing. So we have to remember that when we're looking at our colors, red, yellow, green, whatever instrument you're looking at, remember, kind of what your patient is, and are they being compared to other people that they should be compared to? Because a lot of times they're not, and the computer's just doing the best job that it can do based on the database that's in it. So keep that in mind. Next, we'll move on to the nerve fiber layer area. And I think a lot of times, we'll look at scans like this, and we'll just kind of get caught up in the colors. And those are important, but they're not the most important. I think what's more important to me is the pattern. We know that with the normal anatomy, we're going to see supratemporal thickening and infratemporal thickening. And so this is a completely normal patient. And if the patient is really myopic, if this was a -8 or -9 or further, we're going to see that extend more temporally. If we're going to have, if we have a patient that's maybe a +3 or a +4, we might expect this to be more vertical. So we have to keep that in mind. And those changes, those anatomic changes that are normal sometimes based on the prescription, will throw the database in disarray. So you might start seeing red in these areas, but it might be fine. For example, I had a patient recently that had situs inversus. So their supratemporal and infratemporal, they were way out here, and then it came over like this. So the clinician who was monitoring the patient saw all this red because compared to the Norma database, it was driving it crazy. But that was just normal for that patient. It was not a glaucomatous type of situation. And we also can't forget the anatomy. So here's an artist's rendition of the axons. And so if we superimpose this on this, we have to remember, we want to always correlate it to the direct anatomy. Don't get too hung up in these color codes around the circle. Look at the pattern. All right, so there are metrics that we can look at, and I won't go into all of these metrics, but you can kind of see the right eye and the left eye both give metrics for each. And I don't think there are any one metric that is that much more important than the other. However, I do think it's a good idea to look at average nerve fiber layer thickness. So this is one of those parameters right here. And all of the instruments have that metric, average nerve fiber layer thickness. And if you see that it's less than 75 microns, or if you see that one eye is 9 microns or more different than the other eye, that would raise a red flag. So in this particular example, right eye and left eye, the average nerve fiber layer thickness in the right eye is 98 and in the left eye it's 72. So that's a difference of 26. Of course, that should raise some red flags in this particular example, and particularly in the left eye, it's 72, so it's less than 75 microns. So try to keep that in mind as you're evaluating those metrics. Again, the pattern is really important to me. And so we can see this is the pattern of a normal reflectance pattern that should pretty much go all the way out to our circular area. And here's an example of an abnormal pattern where we just see that reflectance pattern get cold. We see some of those darker colors right here. And in this area, we can maybe see some thinning, and that's registering on the normative database. So look at the pattern. Pay attention to the normative database, because green, it's within 95%. Red is typically, it falls within less than 5%, and then red is less than 1% of the normative database. So keep that in mind as well. Moving on to the ganglion cell complex, we have, again, an artist's rendition of the normal anatomy. So when you just look at this green circle here, and all of them are fairly similar to, regardless of the actual OCT unit that you're using, but in the Avante's case here, we see just a green circle. But remember what that green circle represents. It's a thickness of those axons right around the macula that's decentered a little bit temporally, so right kind of in this area. The ganglion cell complex, when it comes to the Avante's imaging, the ganglion cell layer here, the nerve fiber layer here, and the interlimiting membrane here. So it's putting those three together and along with the inner plexiform layer to kind of image those parts of the eye. Other instruments do it slightly differently. Heidelberg takes the full thickness. Cirrus takes a part like that. We now know how important that central area is as it relates to glaucoma. In the same way that you can hang your hat on a metric in terms of nerve fiber layer, you can do that with ganglion cell complex as well. If the inner eye asymmetry is greater than 5 microns, that should raise a red flag. Or if you see the pattern across the temporal horizontal raphe, if you start to see a pattern like this right in this area, you would expect that to be most likely glaucomatous. So keep that in mind. So normal on our left, a classic arcuate glaucomatous type pattern on our right. All right, so let's just go through a couple of these, and I'll kind of approach it the same way. I'll approach it with you the same way I approach it as I walk through this. So when we look at the right eye, here's the nerve fiber layer, here's the ganglion cell complex. And when we look first at the nerve fiber layer, I want to look at the pattern, and I say to myself, well, that looks pretty good here, but that almost looks like it cuts off a little bit in this area. And then I'll look at the normative database and see if it's flagging. We see that, yes, it's flagging at both here and here. And then, but I look inferiorly and I say to myself, okay, that looks pretty thick there. That looks good. But this area here looks like it could be an issue. We could have some thinning here. And then as I look over to the ganglion cell complex, and we can't just, think of these as two different things. It's kind of an extension of the same thing. And so as we look, we want to, from an anatomical standpoint, kind of look across here and say to ourselves, all right, is it thinned in this area? Oh yeah, it is. Look at that. Now, if I would go back and extend it and say, okay, well, that makes sense, because I was already suspicious looking at the nerve fiber layer. So that's the way I would approach the right eye. And when we go to the left eye, I look at the supratemporal pattern. I say, wow, that looks really thick, and it goes all the way out. It extends. It doesn't seem like there's anything missing here. And in the left eye, I say, infratemporally, I say to myself, okay, that looks pretty good there. Maybe we're missing a little bit here, and maybe that's affecting this normative database, but the ganglion cell complex sure does look good there. So I'd say definitely some concerns with the right eye, probably fewer concerns with the left eye. Then we look at the asymmetry, the right eye compared to the left, and we can really see quite a bit of a difference there. Again, if we get involved in the metrics, we can see that that's, at least we're getting one area that's being flagged. Here's another example. So if we look at this right eye, we can first look at the pattern. Okay, supratemporal, it just kind of stops and gets really thin in this area. And then, okay, is it registering on the normative database? It is. And I'm going to follow that over to the ganglion cell complex. And I said to myself, wow, the ganglion cell complex actually looks pretty good. So how do we explain it? Because that looks so clear cut. Well, one possibility is that this thinning, this arcuate pattern is actually going kind of right across it, and it's being just barely missed by the ganglion cell complex. So that's one way to look at this. In the left eye, we see supratemporal, it just kind of ends right in this area. So that's a little bit of a problem. So that gets my attention. Infratemporally though, it just is not there. We say, well, it is still okay kind of over in this area, but this area looks super thin. And then it's registering on the normative database. It's being flagged both in this sector and this sector. And then the ganglion cell complex, you can see, is just completely wiped out. So we can see, okay, we state ourselves, this nerve fiber layer is in distress more than likely, and this is all washed out. And we can confirm that looking at our Tisnet chart over here, or comparing the right eye and the left eye. It's being flagged in a big way. Okay, so another example, the right eye, supratemporal, being really thinned out here, being flagged on the normative database. As we follow the anatomy over, the ganglion cell complex is being flagged in a huge, huge way. And so very suspicious supratemporally. In the left eye, as we come over here, supratemporally, it actually looks from the normative database, it looks pretty good, but it looks like it could be thinned out in this area, and it is registering on the normative database. And if we follow that across, this looks quite abnormal from a ganglion cell complex standpoint. Infratemporally, doesn't look bad. This looks good, but it is being flagged in this sector, and we might be seeing a little bit of ganglion cell complex in this area, but the asymmetry is striking right eye versus the left eye. So that's another example. Okay. One further example, right eye, supratemporally, a little thin in this area, being flagged. Ganglion cell complex surprisingly look good, but in the left eye, we see all kinds of problems. Supratemporally, it just kind of thins out and doesn't look good, being registered on our normative database. Infratemporally, it just stops being registered here, but look at this ganglion cell complex, both superior and inferiorly, it's being completely wiped out. Lots of asymmetry, so a big, big concern in that left eye. All right, so that's kind of looking at conversion. Has this patient converted by converted to glaucoma? Can we tell that by OCT? But let's next discuss glaucomatous OCT progression, because it's a slightly different thing that we're looking at. We have to understand some concepts like event-based or trend-based. Event-based, this means that we're just comparing one scan to the next. And has it changed from the first scan to the second scan? Whereas trend-based is looking at a series of sequential tests. Is it changing over a longer period of time? And there are strengths and weaknesses to each of those. So here's an example of a progression analysis. So the way I look at this is as follows. So here's the baseline here, and every test after that is put in chronological order as we go across. And so this is the ganglion cell complex. This is the nerve fiber layer part as we go across. In this area is the ganglion cell complex trend analysis, and in here is the nerve fiber layer trend analysis. So I know at least that OptoView and the Cirrus instrument can independently look at the progression of a ganglion cell complex and nerve fiber layer. I think some of the other companies are not doing ganglion cell complex progression analysis quite at this point, but they will soon. So looking at this from an event analysis is simply looking at this pattern and comparing it to this pattern. And I think we can all really easily see that there's a big difference between scan 1 and scan 2. So that would red flag our event analysis. And if we look at the nerve fiber layer pattern here, we'd say, well, that looks pretty good. That looks pretty good. Maybe a little bit thin here. But when we go from scan 1 to scan 2, a huge difference in the nerve fiber layer. So using our event analysis, we can certainly see that there is a change from scan 1 to scan 2. And then if we use our event analysis looking from scan 2 to scan 3 in the ganglion cell complex, it's hard to tell because the ganglion cell complex is so wiped out that you really can't tell a difference going scan to scan. But in the nerve fiber layer, at least, between scan 2 and scan 3, we might be noticing a little bit of a difference here, but between scan 3 and scan 4, it actually looks maybe a little bit improved. So we don't want to be fooled by things like that. But then when we look at the trend analysis, we can see the ganglion cell complex is being changed at a significant amount. This is a fast progressor, and the nerve fiber layer is a fast progressor, mainly because the baseline was so great from point 1 to point 2. And so the other thing that we notice here is how far apart are these gray areas. That's looking at your confidence interval. So is the instrument confident that it's seeing the progression that it thinks it's seeing? And so if those gray areas are really tight, that's a good confidence interval. If they're really far apart, that's a wide confidence interval. And so those are things to keep in mind. We can also look at progression using our Tisnet analysis, where our baseline here is in the dark color here, and then our most recent is down in this area. So we can also see how much change we're seeing from baseline to follow-up. All right, so let's talk about the pros and cons of event-based. It's easy to use, it's pattern-based, and really glaucoma is a pattern-based disease. And sometimes we don't want to complicate it any more than that. You're looking for very certain patterns within glaucoma. And once you see a few of these patterns, it makes identifying subsequent patterns much easier. You can use reflectance images, you can use Tisnet to do event analysis. The drawback is you can miss slow progression. So, you're kind of looking at a pattern from time to time. If there's only a mild change, it's more difficult to pick that up. Event-based can be susceptible to outliers. You might identify false progression, and there may also be a floor effect because once you hit a certain number of microns, maybe that's around 55 microns, then it's going to be difficult to, as I showed you in the ganglion cell complex pattern on that previous example, it was tough to tell because they had already hit the floor. Okay, so now let's look at progression that we've already gone into to some extent. The pros of trend-based progression is it's less susceptible to fluctuation because it's looking at change over a certain time period, but it requires a large number of tests. And so pay attention to those confidence intervals, as I mentioned, if they're really far apart. And that's how the OptoView does it. Each instrument does it slightly differently. So just make sure that you understand understand what the confidence intervals are and make sure you're paying close attention to them. But you can also hit the floor when it comes to the trend base. But you need a lot of tests to get the trend base going. And for many instruments, you need at least 3, 4, or 5 scans to really get a good trend base. So if you're doing scans every 6 months or every year, that could take years for you to really pick up a trend. So I think early on, I like to get more scans on the front end until I'm at the point where I'm getting an accurate trend analysis. So here would be another example of kind of looking at change over time, where we see a very suspicious looking pattern in the ganglion cell complex. And as time goes by, it doesn't look like that pattern is changing much. When we look at the nerve fiber layer from a pattern standpoint, it doesn't look like it's changing much. The Tisnet isn't changing much. And when we look at the ganglion cell complex trend analysis, we can see how tight that confidence interval is. So we could really hang our hat on that and say, we don't think that that's changing in the right eye. The nerve fiber layer, the confidence interval isn't so good. It isn't quite as good. So maybe we put a little more weight in the trend analysis of the ganglion cell complex than we do in the nerve fiber layer until we get some more accurate scans down the road. All right, and another example would be nerve fiber layer, the ganglion cell complex. As time goes by, using our event analysis, there's a change from here to here, and here to here, and here to here. And as we go across, we're seeing a change in that pattern. And from a nerve fiber layer standpoint, we can see that the supratemporal, that pattern is pretty good through here, but maybe right in this area, we start losing a little bit of that supratemporal area. Infratemporally here, we have this, a change from here to here and so forth. And then we look at the ganglion cell complex trend analysis, and that's changing a little bit over time. And so is the nerve fiber layer. On the OptoView, if you get a dark purple, that means that that's significant. If you get a pink, it says it might be significant, and if you get no color at all in this area, then the computer, the progression analysis doesn't really think it's changing. So we have good confidence intervals here, and we have dark purple. And again, each one instrument works a little differently, so just make sure you understand what those colors are telling you with your particular instrument. But this looks this is significant. We think that this is progressing by many different methods, and we want to get more aggressive with this particular patient's treatment. On this particular example,
Hey, Mike, before you go too far into, can you skip back a slide?
I can.
I also know what it's like to do a webinar and be the only guy, so I'm going to give you a little bit of breather there if you want to take a sip. I want to remind everyone that the chat box will be for questions, but I also thought it was kind of cool looking at this, and I work with a similar instrument. Looking at the 2010, the focal loss volume and the global loss volume are green, and then if you go to your last scan, 2018, how it's progressed to the red and the yellow, becoming definitely glaucomatous there, and then showing even more of a global loss. Do you want to point that out on the scan there, where that is?
I appreciate that, Greg, very much. And so let's go to that slide again. And so what Dr. Caldwell is adding to the discussion is that at baseline, and when we look at all of these metrics, including the FLV, which stands for focal loss volume, and the GLV, which stands for global loss volume, we can really kind of see here that from baseline to subsequent, we're getting a red flag in the inferior GCC and the focal loss volume and the global loss volume, along with the average nerve fiber layer and the inferior nerve fiber layer there. So that's another way of using kind of an event analysis to show as time goes by that there is change. So thank you for that, Greg. Okay, next thing I'm going to do here is we're going to take a look at this scan. As we take a look here at the pattern of the ganglion cell complex, we can see in this particular instance that the ganglion cell complex, as time goes by, it's hard to tell from that pattern whether there's change. So in this sense, we hit we kind of hit the floor on this particular pattern. Whereas the nerve fiber layer, as time goes by supratemporally, it looks like we're getting a little bit of a change because we're starting off kind of in the yellow here, and then it goes to red, and then that pattern does seem to change slightly. So supratemporally, we want to keep that in mind. Infratemporally, as time goes by, that pattern isn't changing much, but it is. It is changing. So this looks a little thinner. This little tip looks a little thinner in this particular area than it does here. So we want to keep that in mind. So if we look at the ganglion cell complex, we say that's a nice tight confidence interval, but it does seem like this is super steady and not changing, maybe because we already hit the floor in that particular case. But in the nerve fiber layer, we're still getting a significant trend, a significant decrease, and that's what's being registered here. And to Dr. Caldwell's point, at least in the superior nerve fiber layer, that started off green and that converted to red at some point, and where the rim area started off green and converted to yellow. So we want to get more aggressive in this particular case as well. In terms of high myopia, what do we pay more attention to, the nerve fiber layer or the ganglion cell complex? Or maybe it really doesn't matter, does it? I like to pay a little more attention to the ganglion cell complex. Here was one study among many that showed a difference in the ganglion cell, that showed the ganglion cell complex was a little bit more immune to weird fluctuations due to high myopia, whereas nerve fiber layer, when you start to get parapapillary atrophy around the optic nerve, that'll play havoc with your normative database and with your nerve fiber layer pattern. And so it seems like those forces that thin, that when the retina is thinned, it doesn't affect the central part of the macula nearly as much as it affects the nerve fiber layer. So I pay a little more attention to the ganglion cell complex in high myopia. But what about OCTA? We've heard a lot about OCTA recently, and is that applicable to glaucoma? There are some studies that really, and some of them are from Dr. Weinreb's group, where they're looking at whether or not OCTA can pick up early change, and the early results seem to indicate that you'll see changes in the vasculature prior to, very early on in the process, certainly prior to the point where we see visual field change, and possibly even to the point where we see conventional OCT change. So here's one example to look at OCTA as it relates to the glaucoma. So this patient was a 66-year-old who came in, was sent in because of asymmetric pressures, 15 in the right eye, 25 in the left. He had a history of trauma in the left eye 25 years ago. His pressures by ORA, ocular response analyzer, were 16.5 in the right eye and 27 in the left eye. Corneal hysteresis was 12.3 in the right eye and 9.7 in the left eye. The pachymetry was 590 and 592. The cup to disc ratio was 0.5 by 0.5 and 0.6 by 0.6. So when we take a look at all of that information, we say to ourselves, okay, there's definitely some risk factors in that left eye. So we ran all of the tests on him. Visual fields were completely normal. Standard OCT was completely normal. ERG was even completely normal. And so, the only factor that really kind of made us nervous, one, was the pressure was high, two, the corneal hysteresis was thin, and three, the cup to disc ratio was just a little asymmetric. So we told this patient, there is probably enough justification to treat you. And so we talked about treatments, and he said, doc, I understand that, but I don't want you to treat me unless you are sure that I have glaucoma. And we said, well, all right, we think that you do, but we can't say for certain. He said, well, then I don't want to be treated. Just continue following me along. And if you feel like I absolutely have glaucoma, you tell me that and we'll be treated. So we said, okay, all right. So we followed him about every 4 months. We followed him really closely, looking at every method we could, including ERG change over time, visual fields, OCTs and OCTAs. Nothing changed except for OCTA. So here's the baseline in the right eye. Here's the follow-up in the right eye, and here's the baseline in the left eye, baseline and subsequent in the left eye. And even then, looking at some of this non-perfusion areas, we could have probably said it's being affected at baseline, but I didn't recognize that at the time. It was earlier on in my OCTA usage. But here is a measurement of superior small vessels, inferior small vessels, and whole image. And so the right eye is in blue, and we can see that over time that's staying fairly similar. But the left eye with the higher pressure is in red. And we can see that that is changing, that is actually decreasing as time goes by. So at that point, I can confidently tell the patient, we are seeing something that more than likely indicates that this is glaucoma. And even though I can't tell you for sure, there's enough evidence that my official recommendation is even stronger. You need to be treated. So he said, okay, all right, I'm on board. Let's go ahead and do that. So we treat him in that left eye with a prostaglandin. And he came in 1 month later. His pressure was down into the teens once again, and this is what happened to his OCTA, where we got almost back to baseline in terms of his vessel capillary density, or his perfusion, maybe another way to put it. So we think that was a real reflection that we're actually improving his glaucoma status. Oftentimes we think about glaucoma as a one-way street, but this can actually mean that it's actually improving. Something is improving. So it's expanding our mind as it relates to glaucoma management. Here's another example where kind of a similar thing, only in the other eye, where we started seeing a decline right here, and then we started treating, and we see stabilization back to baseline. So that was another. Here's a bigger view of it, where it was kind of going in this direction, not doing so well. We treat them, they come back, and this is what we see. So it's always good to see that. We think that the treatment and lowering pressure is affecting perfusion. So maybe we're seeing that this tissue is sick. The ERG people have been saying that for years, that you can have a sick retina before that it actually dies. Even though with glaucoma we typically think of it as a one-way street, we might be able to catch it while it is still sick and not dead.
Hey, Mike, while you're taking a real quick break there, we have a question that has come in.
Yeah.
And then I'll read the question, but I'm going to make a comment on that, which you're making comments on that recovery there. Yeah. The question is there a significant numerical value of retinal nerve fiber rate of change, or GCC rate of change that you're looking for? But think about the answer there. Sure. And I just want to make a comment on, the OCTA and seeing this recovery and seeing improvement. We've also seen that on the visual fields. I've seen patients that, their trend goes up, and you go, oh, they just become a better test taker. And and it's not really those retinal ganglion cells that are stressed, but yet you take the stress off and you allow them to recover, you can get an improvement on the visual field. So I've seen it on visual fields, and I've seen it with the OCTA. So it is kind of neat, and I just wanted to highlight that, because I think that's a great point of tonight, is that we do see some reversal with glaucoma, especially now that we can measure at these micro levels and these really sensitive levels on a visual field. So with that being said, I'll let you take our question again. Is there a significant numerical value of retinal nerve fiber layer rate of change, or GCC rate of change?
Yeah, so there's this. So the answer is that there's several studies out there. I wouldn't say that there's necessarily consensus on the matter, but when we talk about fast progressors, those are the ones we have to be the most aggressive about in terms of treatment. And so it's generally accepted that if you have one micron per year or more, that's considered a fast progressor. I have seen that go down as low as 0.8, but typically, what's normal for an average person who's just aging? What's their rate of change? And we kind of think that that's about 0.25 in that range, 0.25 microns per year, anywhere from 0.15 to 0.25. Is an average rate of change. So certainly for it to be pathologic, it has to be greater than that. And so be really careful about the fast progressors, which is 1 micron per year or more. If they're in a 0.75 to 0.1, that's a concern as well. If they're less than 0.5, maybe that would be maybe that's just variation. Maybe that's artifact. If they're less than 0.25, then that would be okay. But the point is the higher that is, and each instrument has has their own method of assessing. But I think we as clinicians, if we see the fast progressors, we have to get more aggressive. So 1 and over, but I would go as low as probably 0.75 and higher. Pay close attention to that. But if you're 0.25 and below, I'm not too concerned by that. One final point that I would jump on about Dr. Caldwell's comment, which is an excellent point that he raises, is that in the OHTS, how many visual fields did it take before they were convinced it was progression? It was many. It was several. And so I heard at least one speaker who was involved in the study say that it's because it was maybe flickering out. That visual field was flickering out slowly. So we thought it was due to maybe they had a good day or bad day, but maybe that's the way that visual fields work. So I think that we need to start thinking about glaucoma as not being a one-way street. You can interject, and by lowering pressure, you can rehabilitate in many cases. You'll see it on ERG, you'll see it on OCTA, and as Dr. Caldwell said, you'll see it on visual field. Another benefit of OCTA is picking out nerve fiber layer defects. When we look at this patient, we can all see this nerve fiber layer defect. It kind of jumps out at us right here because we also see a drantheme. And so if you see a drantheme, a lot of times you're going to see a nerve fiber layer defect, and that's exactly what we see. But in this particular case, look how OCTA just brings it right out as well. And so we can see it really, really easily. So it's nice when we kind of compare this to some of our metrics. I like to see at least a 50 in these patients. And so in the right eye superiorly, we're seeing a 55, but the left eye we're seeing a 46. That's indicating not as much perfusion as we would like. We also see that there in the reflectance pattern. Okay, another example, we all saw in that previous example that nerve fiber layer just jumped right out to us. But when we look at this particular picture here, we can. It's really kind of difficult to tell. It was also difficult to tell clinically whether there was a nerve fiber layer defect. But the OCTA really brought it out. There's a nerve fiber layer defect right in this area, and we can kind of see that in this pattern as well. So OCTA really helps identifying these nerve fiber layer defects at a higher level, I think. Want to see more glaucoma? Consider doing an eye wellness program. It was actually Dr. Caldwell that helped convince me that we wanted to do that in our practice. And I can't tell you how many more epiretinal membranes we see, AMD we see, macular edema we see, but even glaucoma. Patients of mine who I've been following for years that I've not suspected glaucoma, we do an eye wellness, and I see a little bit of thinning on their eye wellness scan, and it helps me identify something that I had trouble seeing clinically. And we go back and identify, yes, they actually do have very early glaucoma. So it's been a good thing. As we, as a profession, move towards the medical model, eye wellness programs are good for getting more involved in disease, and they're good for the patients with early diagnosis. All right, so those were the first two. Those were that second one was really involved. The next ones will kind of fall a little faster. So you must know your angles. So this was, don't be obtuse. This quote is from the Shawshank Redemption that's on almost every weekend in our houses. So you must know your angles. So there are many ways to assess angle. You know, gonioscopy we can do B-scan, we can do we can do a Scheimpflug image, do it that way. We can do OCT analysis. So those are all different ways, and they're all good. And what I would say is, one, I think we do gonio, do it more, but also have an objective way of looking at the angle as well. It's nice to have multiple methods, because there are some times where I get confused when it comes to looking at the angle. If they're really lightly pigmented, it can be difficult. At times, especially if you are maybe a newer practitioner, and you're just learning the art of gonioscopy, having an objective method, it can be extremely helpful. I find that it's helpful in my case. So many different ways to do it. In our practice, we have a Scheimpflug imager. We also do it look at angles by OCT in addition to gonioscopy. So real quick review of angle closure classification. We had a patient just today, that had an angle closure presented with an IOP of about 65, and just a real difficult thing. Fortunately, I, with the help of one of our interns, who I think is on this call tonight, we were able to get this under control. So primary angle closure classification, the PAC S is primary angle closure suspect. It means that greater than 180 degrees of iridotrabecular contact with normal IOP, or primary angle closure greater than 180 degrees of contact with PAS or elevated IOP, and then primary angle closure glaucoma, which is everything included in primary angle closure, PAC, with glaucomatous optic neuropathy. So those are the three classifications. Really important to know those and how to deal with those. To illustrate the importance of angle assessment, we'll talk about this case. 63-year-old was referred to the Glaucoma Institute of State College. IOPs 23.7 in the right eye, 21.8 on the left eye. Patient came in on bromonidine and timolol, both twice a day. Patient was referred for open angle, but a concern with progression. Had grade 2 cataracts, correctable to 20/25, cataract glare to 20/50. So it wasn't at the point where we would normally consider cataract surgery visually, but when we looked at the angle, here's the gonio, and you can see that the angle is fairly close. We see a little bit of trabecular meshwork right in this area. An OCT image shows how narrow that angle is. So ask yourself, how would you manage this particular patient? Would you add more drops? Would you do a PI? In our case, what we did was we did a cataract surgery with goniosynechiolisis. And what that simply means is that we're kind of taking an instrument, the surgeon takes an instrument and pushes down on the iris to try to break some of the contacts. So in terms of chronology, you take out the intraocular lens first. That kind of opens up the angle a little bit. Then with your instrument, you try to push down on the iris to try to break the anterior synechia, which in this case we were able to. And because he was successful in opening the angle and breaking the synechia, and it can be difficult breaking synechia if it's been there for longer than 6 months. Within 6 months, there's still a good chance you're going to break them. And you can break them even, 9 months or a year, or sometimes even longer, but there's just it can be more difficult. And sometimes you just push, and you're not going to open it. All you're going to do is cause additional trauma. So, but because the surgeon was able to open the angle by goniosynecholysis, he was able to do a KDB procedure, kind of a gonio removal, was able to perform a goniotomy, which exposed, opened up the trabecular meshwork in this area. And what we're looking at, this whitish area, that's the back wall of the canal of Schlemm. And so you get rid of some of that trabecular meshwork obstruction, and it goes right down to the next level. And so fortunately, and so here's a before and after OCT, and you can see how wide open that pressure or that angle is now. And so with that particular patient, at this point in time, he's 2 years out, and he's not even on glaucoma medications, and he is not progressing. So it was truly, the mechanism was strictly an angle mechanism, and when you resolve that, he's been great ever since, and certainly the goniotomy was helpful. Another important thing about objective assessment is, one nice thing about OCT angle analysis is you can do it under really good scotopic conditions. So you can see here in the top view, this patient was taken in scotopic conditions enough that her pupil opened up nice and wide, and we can see how narrow that angle is. This same patient under photopic conditions, it opens that angle wide open. So a lot of times when we're doing gonioscopy, even if we're careful about keeping the illumination low, even if we're careful about keeping the illumination in the angle and not in the pupil, you're still going to get some ambient light that's closing that closing that pupil down a little bit more and opening up that angle. So it's nice to have OCT to be able to do that. A lot of the newer OCT instruments are doing angle-to-angle analysis, which is a lot easier to kind of view that the whole iris shape. There's the Schonflug imager that we use in our office, and you can see in this particular patient's case that this iris configuration is really, really narrow, leads to a really narrow angle. We can also look at the anterior chamber depth, and anything lower than 2.5 is a big concern, and the chamber volume, anything less than 100 is a big concern. So that's another nice way of doing it. So to reiterate, angle assessment is critical. And I can't tell you how many cases of presumed open angle referrals that we've got that were actually, narrow angle, chronic angle closure. And so we manage it differently when we know that there's an angle issue. Instead of piling on drops, we take care of the angle in whatever way that we need to. So really important. All right, the number four way, telemedicine. The allure is that it will transform optometry. We've all, most of us on this call probably used telemedicine during the shutdown. It was an important tool to reach out to our patients. Maybe it generated some revenue, but the reality is that it's going to evolve into a small but significant percentage. But it's really going to be a small portion of our practices. I think we should embrace it. I think we should get on board, and we are. But it's not the panacea that I think we at least I thought it would be when we started doing it. But there are some pathologies that work really, really well for this. Those pathologies include subconjunctival hemorrhages. How many of those, do we see coming into the office on a daily basis? Sometimes we can screen those out by telemedicine. Dry eye, that's a great way to talk with patients, because a lot of times these patients, you really need time with them to kind of work through all the many things that they've tried and the plan ahead, coming to a consensus. So dry eye, I think, is really good for that. But what about glaucoma? Is there any telemedicine applications for glaucoma? We're doing a pilot program within our office where when I put a patient on a new drop, or I adjust drops in some ways, I'm having one of our technicians reach out to that patient through telemedicine a week or two later. And so what the purpose of that visit is, one, so that our technician just can kind of work with that patient and reinforce what we talked about in terms of their eye drop schedule. Are they experiencing any side effects at that point? And they will actually then show the patient, the patient will show our technician through telemedicine their insertion technique. And if there's anything obviously wrong with their insertion technique, then we'll have them back in for another visit, not with the doctor, but with the technician, to just kind of go through that with them again. One of the biggest problems in glaucoma is compliance. And with this program, we hope we can improve compliance, as well as just giving another clinical touch point with the patient, a communication point with the patient. One other thing we started doing during COVID is we started doing a virtual scribe. In our office, we use a lot of scribes. And so I'm always having someone else in the exam room who can input that information to me in a very efficient way. But now we started doing that virtually. So here's an example. I'm seeing a patient, and right here is our virtual scribe. So our virtual scribe has access to our cloud-based EHR and can also look at, have their own computer. And I'm asking our scribe questions. I'm talking with the patient. Sometimes I'm inputting data myself. It makes for a super efficient way of examining that patient. And I spend so much less time with my back to the patient than I did before scribing and before virtual scribing. So it's really a neat thing for our office. Other ways to telemedicine, there's a company out there called 2020 Now. I have no vested interest with them, but they're getting involved in telemedicine quite a bit. There is a group called Telesite, which I'm a consultant with. That if you're interested in getting a second opinion, in our practice, if I need a second opinion, I just go across the hallway. There's a Telesite app that can allow you to do the same thing. Again, I'm a consultant for them, and so take that with a grain of salt. There's a glaucoma module through a program called NetView that we're trying to work with to do some telemedicine. So there's all kinds of ways to do telemedicine within the field of glaucoma, and we're just kind of scratching the surface. But I'm excited to see where it leads to. Number 5, foster an appreciation of corneal hysteresis. Hysteresis is the cornea's ability to absorb and dissipate energy. So it's like, how is your cornea shock absorber? And why is that even important? Well, because if you have an elastic cornea, that means you have an elastic eye. And if you have an elastic eye, when you undergo pressure changes, that eye is going to be able to absorb some of that energy. If you have a really rigid cornea and a rigid eye, and you have those fluctuations in intraocular pressure, a rigid eye has nowhere to dissipate the energy. So that energy is going to, potentially be dissipated by the optic nerve and the nerve fiber layer and the ganglion cell complex. All right, so how do we measure it? There are many different ways to measure it. This is my homage to Billy Joel. It's just kind of a souped up NCT, essentially, the ORA instrument. But the sensor not only measures the cornea indentation, but it measures how the cornea goes back to its normal shape. So that's really the difference, and it's a powerful tool. Which is best? You know, they're all good. They're all good to use. But I like the in our office I use the ORA. For a while I was doing Goldman and ORA, but pretty much I do ORA. Not only am I happy with the accuracy, but as I mentioned in my risk factor part, corneal hysteresis is a powerful risk factor for glaucoma conversion and progression. It's one of those, you know, conversion and progression factors that's so important. This study showed that corneal compensated IOP may represent a really accurate way of pressures, especially in a certain pressure range. This study showed that hysteresis was the parameter most strongly associated with visual field progression, most strongly associated with visual field progression. So it really is a very, very valuable piece of information to have. It's less influenced by corneal properties. You know, one way we can tell that is that after LASIK, you know, what happens to most people's pressure? It drops. And this study showed by 26%, and that sounds about right. But the ORA pressure only dropped by 3% after LASIK. So it's much less influenced by corneal properties. A lot of times we're reclassifying patients that we thought were NTG. They're actually, you know, conventional POAG and vice versa. So it's nice to have those accurate measurements. All right, number 6. This number 6th way of jumpstarting your glaucoma practice. The topical treatment Easter egg. The Easter egg was a concept started by the game Adventure back in the 80s when I was playing a lot of those video games. And so it means kind of like a neat surprise. So hopefully we'll be able to throw a couple topical Easter eggs your way. One neat thing about this particular meta-analysis is it reviewed lots of data and it converted, you know, the pressure reduction into a percentage by ingredient. So it really kind of went through all of these different ingredients and threw out a percentage reduction. So it's really nice to kind of see those as it relates to our patients. So I often go back and refer to this this chart and just kind of get a sense of how much I should expect. And if I don't expect, and if I don't get that much, then maybe we consider a different drop. Therapy with the beta blocker. We know that it's inexpensive, it's nice, and I will use it in a morning, you know, as a morning dosage. But I rarely, almost never, use it at a nighttime dosage because beta blockers don't do much with the nocturnal pressures, and so all you're really doing is potentially slowing down, you know, the heart rate, which kind of works against you. So I'm still using beta blockers in the morning, but I almost never use it at night. And you say to yourself, well, yeah, but if I want to prescribe a combo, it contains a beta blocker. Yeah, that's true. And so if you want to do a combo, certainly don't do it before bedtime. Try to move that up to, you know, 4 or 5 o'clock in the afternoon as opposed to using it before bed. ROCK inhibitors, you know, we've had a chance to use them now. It does create side effects, no way around it. Some of those formulary issues are being, you know, are going by the wayside. But ROCK inhibitors, I find that if you have a patient with a pressure of 30, ROCK inhibitors may not be your thing because it may not reduce it all that much. But if you have a patient with a 12 pressure or a 14 pressure or 15 pressure and you need to get down 3 or 4 points, I think a ROCK inhibitor is really good in those kind of patients. So normal tension glaucoma patients, that's, you know, a lot of these patients that we're talking about, that's a really good way of trying to get that pressure down a couple more points to get that stability that you want. Wish it didn't have so many side effects. Alpha agonists, we use them a lot. They're really well tolerated, but the point of even mentioning alpha agonists is that, you know, on one hand, the low jets study, the low tension glaucoma study, used alpha agonists as a treatment. So it's really generally accepted a way of doing that. However, one of the possibilities is it can lower the blood pressure. And so I had a patient recently that was referred to the office, that the patient that was put on Alphagan, and she said after 2 days of using it, she saw her visual field. She was really in touch with her visual field. She felt that it expanded, and upon further testing, it actually did. And so be really careful about those types of patients. It's hard to predict who it's going to affect in that way. But if you have a patient, now I mention it to all my patients that I put on an alpha agonist. Hey, if you notice any changes, if you feel sluggish, if you feel like kind of run down when you start it, just stop it and let me know that. How about Rocklatan? The reason I mention this is because, we all have those patients that come in and they are one step away from a trab, or they come in and they may have pigmentary glaucoma and they come in with pressures of 50. You're like, oh my goodness, what are we going to do in this particular case? And so Rocklatan has been a really good tool to maybe delay trabs. Maybe it's a tool that I can get a pressure of 40 or 50 down to 20. It's been amazing in that way. Sure, it's not great from a formulary standpoint. It is expensive as heck. But when you need a big gun, I'm not sure there's a bigger one in terms of bringing the pressure down. All right, number 7, glaucoma and ocular surface disease, becoming more and more tuned in with that. Why? Because what do we prescribe most of the time first line if we're going to prescribe a medication? Usually it's a prostaglandin. It's good. We know it's safe. We consider it pretty benign. With that said, there are a couple things that can create a problem. Conjunctival hyperemia is an issue. SBK is an issue. Meibomian gland dysfunction is an issue. And this thing called PAP, prostaglandin-associated paraorbitopathy, it is an issue. And we say to ourselves, well, it's not that big of an issue. Even though we can spot these kind of patients, is PAP really that big of a deal? Well, I would contend that PAP is a euphemism. It's it's a lot worse than what happens to these patients is as they lose their fat padding around their eyes. We'll call it PAP, but it's worse than that. What it is really skeletonization. I was sitting in on a CE given by a dermatologist who was showing something completely different and showed a picture just like this and said, oh, this is a patient with skeletonization. And when we say to ourselves, wow, yeah, that really is what it is. That's really kind of what these patients who have been on prostaglandins for years, they have skeletonization. If we would call it that, maybe we wouldn't be so, cavalier about thinking that prostaglandins have no side effects. So all of those things kind of hit me over the head over the last few years, along with a growing realization that these medications that we're prescribing with preservatives, rates of non-adherence to treatment are nearly triple in patients using preserved as opposed to preservative-free medications, primarily due to the prevalence of ocular surface disease. So it's not only just the PAP that's created, it's this ocular surface disease that these preservatives create. And so here was a recent article that came out and said something very strong, and that is, again, triple non-adherence is triple in patients using preserved as non-preserved. So that's I hope that hits home with you when we talk about prescribing these medications. Of course, drugs don't work for patients who don't take them. So Quigley found in this 2008 study that 50% of patients discontinue topical treatment within 6 months. Why? Adverse events, ocular surface disease, cost. So we wonder sometimes why adherence and compliance is not great with some of these topical agents. But when you see a patient who's been on these medications for years and see how much ocular surface disease they have, it's overwhelming. we started doing running a inflammatory procedure on all of our patients that were referred into the Glaucoma Institute. And in the average population, in that same range, you might expect a 15 to 20% to be positive on that test. On inflammatory, we found about a 70% positive rate. So we know that these patients, who are using these medications long term, it causes problems. What it does tell us about dry eye, it's a multifactorial disease. You have a loss of homeostasis. You have tear film instability, hyperosmolarity, ocular surface inflammation, neurosensory abnormalities, all of these things that DEWS2 really in a great way kind of put out there. And we realize that there is something called glaucoma therapy-related ocular surface disease. Glaucoma therapy-related ocular surface disease. And we're really messing with homeostasis because we're using these medications, not just the medication themselves, but the preservatives day in, day out, causing tear film instability, epithelial damage, inflammation. And these patients aren't necessarily happy. Yes, they'll do it, maybe, they'll listen to you, but they're not, there are problems with some of the medications we prescribe. Increase in frequency and severity with the number of drops. So up to 60% of patients with medically managed glaucoma have ocular surface disease, which is 3 times the prevalence in the general population. Our inflammatory numbers bear that out, and even probably go a step further. So we have to be aware of all these things. So how do we address it? In our practice, we utilize a lot of Xioptin, preservative-free, no financial interest with any of these things, but Xioptin is a great tool to use. And one hack is that if it's not covered by their formulary, you can get it directly through their preferred pharmacy in Lakeland, Florida, and for a cost that's less for a year supply. That's right around $400, which is probably less than what they're paying now, depending on their insurance. So that's one really good thing about Xioptin. Preservative-free timolol, another thing. If we're going to use timolol, we'll use it in the morning, and preservative-free option is great. Preservative-free Cosoft, Zelpros. I'm still kind of getting familiar with that. Imprimis and lighters. Making them without preservatives. On occasion, I'll utilize that, but a lot of times going directly to an SLT or maybe a PI in an angle case, or a KDB or some MIGS to help take care of those pressures without bombarding the cornea with BAK. One final thing about that is that BAK, after years of usage, we think might get into the trabecular meshwork and make any future changes at therapies less effective. Why does SLT work well on medically treated eyes better than if they've been on medical treatment for years, particularly with multiple drops? Maybe it's because BAK is getting into the trabecular meshwork and causing some longer term damage. So keep that in mind. So next step is SLT. Where does it fit into your treatment paradigm? So once you make the diagnosis here, let's take a look at this. Yeah, once you make the diagnosis, do you start with a prostaglandin, then do you add another drop, and then do you add a third drop, and then maybe you think of SLT, and then maybe you think of a trab, kind of in that order? Is that your treatment paradigm? Again, compliance. At any given time, we think that our patients are using their medications about half the time. If they have to use, and that's once a day. If they have to use a medication twice a day, in this study, it went down to 39%. If they have to use more than one medication, compliance goes down to 32%. So that really is the elephant in the room of glaucoma. Here was a patient that, back when we were doing cataract surgery, and they had all of those many different medications, and if they had glaucoma medications and all these things, they had a list. So this is madness. This is pure madness, but that's the way that many of us lived, and hopefully we're getting out of those stages. So SLT, reduces IOP 25% at 3 years. We know how, we know the area with targets. It does an extremely good job. And as time goes by, more states will give us the privilege to use that. The Lancet study more recently changed things because it was, up until that point, many studies said, well, SLT could be used, should be considered as first-line treatment. This Lancet study took a step further, and they said it should be, not could be, or it's reasonable to consider. It should be offered as first-line treatment for open-angle glaucoma and ocular hypertension, supporting a change in clinical practice. Now, with all that said, guess how many patients, what percentage of all glaucoma patients in the United States have had SLT? The number is 15%. It's extraordinarily low. Maybe it'll start going up based on this Lancet study, but there is a big role of SLT in our practice. And so it removes the burden of compliance. It works 80 to 85% of the time. Again, there are some times it doesn't work, particularly if that patient has been bombarded with topicals for years and years and years, or many times a day. So it doesn't work 15 to 20% of the time. We've probably done, I don't know, 600 to 700 in our practice, and I can count on two hands how many side effects, significant side effects we had, and all of them were manageable. And I can certainly not say that about topicals and side effects. So, hopefully that brings us some perspective. So where is SLT in my treatment paradigm? Once we make diagnosis, we'll offer them the option of either SLT or a prostaglandin. But in most cases, many, if not most cases, we're doing an SLT first. If we get to where we want to be with the SLT, great. If not, then we'll add a prostaglandin onto that. Or if we start with prostaglandin and we don't get to where we want to be, then we'll do SLT. Then maybe we'll add one. Rarely am I adding a second one because at that point I'm going to a MIGS and then to a TRAB. So that's where my treatment paradigm is. MIGS. So we talked about SLT. Next is MIGS. What role does MIGS play in all of this? And so MIGS is the wild card because patient adherence is the wild card, is it not? We made that point. MIGS, as through the years, has been getting more sophisticated, better, more patients are having it done. But it's still very early in the MIGS, in the MIGS arena. For so early that the CyPass that we thought was a pretty good insert to reduce pressure, we found out was toxic to the endothelium. So it is still very, very early on in the MIGS arena. So iStent is out there. It's good. There's a lot of cataract surgeons who are finally getting on board to the possibility of iStent. Started with one, now we're typically doing two, and it works very well. Here's a picture of an iStent. Here's a picture in the angle of an iStent doing two of those. Doesn't work in all patients because if you don't hit it right, and those collector channels or Schlemm's canal is a little bit gunked up in that particular area, you're not going to get the pressure reduction that you want because the limiting factor in that case isn't the trabecular meshwork, it's further downstream. Doing two inserts and making them a little wider in terms of the flow is a little bit better, more chance that you're going to hit the right place. All right, and so a lot of studies out there that says that iStent, doing one, I wasn't all that impressed with it. Most studies were finding about a 10% reduction, which wasn't great. But doing two with the newest version, the results are a little bit better. We're getting maybe closer 15 to 20%. In some cases, I've even seen higher than that. Next MIGS is Cahook dual blade, KDB. Probably one of the procedures we do most of all. And that's, as I showed in the previous slide, it's removing part of the trabecular meshwork. You can combine it with cataract surgery, but it doesn't have to be combined. You can do it independently without any type of cataract surgery. a good risk reward profile covered by insurance. A lot of times you can get them off of at least 1, maybe 2 drops. You do sometimes see these hyphemas, at the 1-day visit, sometimes the 1-week visit, but they're always self-limiting. And so we don't get too concerned by that. We're trained to, we see a hyphema and it's all hands on deck, but with these hyphemas, it's very minimal. The trabecular meshwork does have to be visible, and so that's an important thing. So if you have an angle that has a lot of PAS that you cannot open by goniosynecholysis, then obviously a KDB is not going to be successful. So the dual blade, there's a blade here, and then there's a blade, 2 blades here, and so we're just kind of using that and going right across the trabecular meshwork. Here's another picture post-procedure where we're exposing that Schlemm's canal and allowing fluid to flow a little further. This was a KDB head-to-head against the iStent, and the KDB was significantly better. However, that was the previous version of iStent, so the newer version might compare a little bit better. And so ECP is another MIGS where you utilize, most of the time while cataract surgery, you utilize a laser and you laser the ciliary body. And that can give maybe a 10% pressure reduction. We used to do a lot of those since we started doing KDB, where we don't do nearly as much or do them at all really at this point, but it's still a lot of people doing them. It's still a good procedure using this laser again to laser the lasering the ciliary body. Zen procedure is like a trab, but you're using you're kind of using this I'm trying to remember what it is. The gel stent. You're using this gelatin stent that's cross-linked with glutaraldehyde, and so this right here slows down, theoretically, it slows down aqueous outflow. So unlike a trab or a tube that it just kind of pours through, this is supposed to give a little bit more control. And it does, but the drawback is that there's a high percentage of patients who need a needling revision, as high as 35%. That's a lot of revisions that need done. And like a trab or a tube, you still have the risk of hyphema, hypotony, all of those things. But it does seem to be a better procedure, maybe not quite as low as a pressure reduction as a trab, but it's a good procedure. All right, and Hydrus is another MIGS. Hydrus is this instrument, kind of this area that has that kind of has it kind of scaffolds open the trabecular meshwork, and also has some collector channels that kind of feed further downstream. Really good procedure with that. Our only concern is that like the CyPass that had a recall, the Hydrus, we hope doesn't have any of those kinds of issues. We haven't seen any problems with it yet, so it is a good procedure, but I think we just have a general aversion to implants of that type until they're proven not to cause any problems. So Hydrus is good. We're seeing 25 to 30% reductions fairly consistently with the Hydrus, so a very good MIGS in that particular case. And then as we kind of bring it on home here, I think it's worth having a brief conversation about trabs and tubes, because sometimes you need them. We had a patient just today that had pigmentary glaucoma for many years. And so he was on multiple medications. Of course, his ocular surface was horrible, strong positive on Inflammadry, all those things. But his glaucoma was progressing. And so we got a hold of him last month, and we said, hey, we'll do one more last ditch effort to try to, because we said what you really need is a trab or a tube. And he said, look, can we make one more chance with medical? And so we had not used Ropressa. So we said, okay, let's give Ropressa a shot, and maybe we'll hit a home run with this. His pressure was kind of in the high 30s last month. And so we did that. We added Rocklatan to the mix. He came in today. His pressure was unchanged. So we said, okay, it's time. We need to go to the next step. Otherwise, with the pressure of high 30s, with moderate glaucoma like you have now, it's not going to be too long until you go completely blind from this. So we need a procedure like a trap. No one wants to do them anymore because MIGS has become more fashionable, and MIGS are good and they're much lower risk. But in this particular case, we needed a higher reward. And so TRAB will give you that high reward. You're going to have a 30 to 50% reduction. In this particular patient's case, like today, it's necessary. You have to do it. But the risk of failure at 5 years, is close to 50%. So you have to watch these TRABs carefully, closely. You have to stain with fluorescein every time they come in, make sure they're not developing any leaks. A lot of times you will see leaks, and then you have to manage those leaks appropriately. And eventually, sometimes they need a revision, which is a difficult procedure. So no one wants to do a TRAB, but in some cases you have to preserve what vision they may have left. Same with tubes. We're a little more likely to do tubes in neovascular glaucoma patients, sometimes exfoliation patients or pseudo-exfoliation patients. So tubes work a little bit better in those particular cases. So there's also a place for tubes as well. All right. So we have kind of hit the end of our lecture part. I appreciate your attention. I appreciate the opportunity. But at this point, we'll take a few minutes for any questions that you have. I'd be happy to do my best to try and answer them.
Mike, great job. You're very knowledgeable in glaucoma. I know this is your passion, and just tonight's presentation and webinar just shows that what a wealth of knowledge you've passed on, and I thank you for doing that.
Thank you for the opportunity.
You're welcome. No questions have really rolled in here. I can give it a second or two before this, or just to see if anything does roll in here. Do you have any, now that you've been able to kind of get out of webinar mode, is there any thoughts that you want to think about or give?
Yeah. So I would just say, reflecting on, what we talked about tonight, I'm convinced that our profession has to continue moving in this direction. And we came from, when Greg and I graduated, we couldn't even prescribe glaucoma medications in the state of Pennsylvania. And now, Greg is a consummate glaucoma practitioner, and I do some things right down the road from him. So the fact that we can have these kind of conversations and practice at a high level in glaucoma, just tells you how far we've come as a profession, but how far we need to go as a profession until we are managing glaucoma at the highest level throughout our every member in our profession. So I appreciate those who could make it tonight and spend some time with us, and both Dr. Caldwell and I are always happy and willing to answer any further questions. If you want to reach out by email or LinkedIn or any other way to help you in your practice get to where you want to be from a glaucoma standpoint or just a disease standpoint.
Exactly. Well said, and a great way to wrap it up. No other questions have rolled in here. I want to thank you again for doing this, and also, also glad that your daughter has recovered from this COVID virus. So, lots of thoughts to you and Autumn about your daughter there. I'm glad she recovered nicely. So, thank you, and a great job. Just a reminder, everyone out there, Vanessa, our conference coordinator, will send your information to Arbo in Cope. That will most likely happen probably on Friday, and it takes about a week to 10 days for them to upload it. Arbo is very busy now, as you can imagine, with all these webinars. So please give them time. And then also Vanessa, through Optometric Education Consultants, will send you a certificate of attendance via the email you use to register for this webinar. So again, thank you, everyone. We're going to log off and look forward to seeing you potentially at a live meeting that we hold or in another webinar. Mike, thank you.
Thank you, Greg.
All right. Take care, everyone. Bye-bye now.